and cared for safely once they're out in the community. So the inpatient unit level of care is when the hospital says, we can't do anything for you, but it's not safe for them to go home yet because the longer-term plan is not in place, and they're not stable enough to go home. They could go to an inpatient unit. They'll either get stabilized and then go home, or it might become end-of-life care, and they might end up dying in the inpatient unit, but they stay there until either they've passed or they're stabilized. It's not long-term. Then you have something called continuous care. Continuous care is 24-hour care that a person gets in the home. So before I said to you, you only get 4 hours a day home health aid in the house. Now I'm telling you there's something called continuous care. What am I talking about? So what I'm talking about is for the same person who has that higher acuity level need of care, but doesn't want to go to the inpatient unit, to the hospice inpatient unit. They want to stay home, and the family wants them to stay home. But they need the extra level of care. So they would be covered by Medicare to have 8 to 12 hours a day home health aid in the house, and the same number of hours, 8 to 12 hours a day, of a licensed practical nurse in the home if they need a licensed nurse to administer the interventions. But because it is such an intense and expensive type of care, as you can imagine, it gets reevaluated every 3 days. And for as long as the person needs to have their symptoms managed with that level of care, it's covered. Then the fourth level of care is something called respite care. Respite care is for the caregiver. If you were managing a loved one in the home and you had to leave town for a simcha or on business or whatever, and you just couldn't take care of your loved one who's the patient can be placed into a nursing home, it would be covered by Medicare. I think it's for 4 days, 4 or 5 days. It's called respite care, and then the patient goes back home. The other reason a person can go is literally for respite, because you have caregiver burnout. The caregiver is just burnt out, and they need a break. So the patient can go into a nursing home for routine hospice care. They're still getting hospice care. It's still covered. It's still the same level of care, but it's in the nursing home. You get a break, and then the patient comes back home. Advance the slide. How often do people come to the house? I spoke to you about a whole team of people. How often do they come to visit the patient? Well, the RN case manager happens to be the conductor of the orchestra. And the RN case manager is available, or hospice care is available 24/7. It's a 24/7 operation. So you're always going to get a person. Like by us, for example, we have a call center on site. So after hours, there's a whole triage team. There's a nurse, social worker, rabbi, you name it, they're all there. We have a whole team. 24/7, you get a person. It's not an answering machine. The RN case manager has to go out a minimum 1 time a week or as needed. Social workers within 5 days of admission, and then as determined by the plan of care. They work with everybody, not just the patient. It could be the caregiver, it could be children, it could be other relatives. They're dealing with whatever needs to be dealt with. The hospice chaplain has to go out within 7 days of the admission, and then determined by the plan of care. With the Jewish patients, we're out within 24 to 48 hours. One of our rabbis has already met with the patients and the family. The hospice medical director does home visits as needed and does the face-to-face visits for the first visit when they are admitted to do a full assessment. And the home health aides, I explained it already. Too advanced. What else does a person get when they're on hospice? They get everything that they need. Durable medical equipment, the bed, commode, walker, wheelchair, reclining chair if they need something like that. They get all of the medical supplies, all of the medications that are specific to the disease that they are certified from their illness. It's all covered by Medicare. What's not covered? Let's say a person has diabetes, but they're not on hospice because of their diabetes. They're on hospice because they had lung cancer, which metastasized to other places. Anything related to their terminal diagnosis, it's covered. Diabetes, they're not going to be covered under the hospice benefit for their insulin. But their regular insurance will still continue to cover it.
What is the DME?
Durable medical equipment, the bed, the hospital bed, the pressure mattress, all of that stuff. And you get oxygen, all of the stuff that you need in the home.
How about like an elevator?
What?
Like an elevator?
I can't hear
Like
you.
an elevator?
An elevator?
No, I'm serious.
Every time
Like,
it goes up the steps.
No, they don't pay for that. You mean like the chairlift?
yeah,
That they don't pay for the chairlift. What would happen typically in a house where a person has hospice is they would create a setting for them that is convenient for the patient because they wouldn't be going up and down the stairs if they weren't mobile. It wouldn't be conducive in a house that's set up like that. They generally set something up where they're more in the thick of things. I went over this, the general inpatient level of care, the IPU. Some of the procedures that are typical for people who go into an IPU would be for blood transfusions. Not all IPUs will do a blood transfusion. We actually, if it's in a hospital you can, but we have the IPU that's in a housed in a nursing home. We actually take the patient when they're symptomatic to the hospital across the bridge for the blood transfusion. Not all hospices will cover blood transfusions. We do. Paracentesis, I don't even know what that is really. What is it? Bowel disimpaction, urinary catheterization, wound interventions. We have wound specialists. And aggressive pain management. And any kinds of sedation to manage their pain or anxiety. Okay, next. Continuous care I also explained. We could pass that. Okay. Hospice family meetings. Hospice family meetings are a very key ingredient of what makes hospice unique. Because in every family there is a spokesperson. If the patient can't speak for themselves, there's a healthcare agent who's been designated as the healthcare proxy. How many people in this room have a healthcare proxy signed? How many people don't? Okay, in the packets in the back is a healthcare proxy. The Halachic Medical Directive is in there. Every single person in this room, every single person that you know should sign a healthcare proxy, because the Family Healthcare Decisions Act that was passed in June 2010 now creates a hierarchy, a surrogacy hierarchy. That means if you haven't decided who's going to speak for you, if God forbid you can't speak for yourself, if God forbid you fall on the street and you have a concussion and you can't speak, somebody that you don't know is going to make decisions for you. If God forbid somebody had a terminal disease or any kind of serious or advanced disease, if they can't speak for themselves, they're going to want to still maintain control over their care, over the decisions, their care decisions. That won't happen if you don't have a healthcare proxy that you trust.
How about children?
Children can be a healthcare proxy. A spouse could be a healthcare proxy. So you have to also trust the person that you're designating. Sometimes the spouse will say, I can't do this. I have a friend who made me her healthcare proxy because she doesn't trust her husband to carry out her wishes. Very often in families, it's a child, it's an adult child that does it because it's too painful for spouses. Every family is different, but the point is still the same. Designate who you trust and have the conversation about what's important to you. People avoid the conversations. It's not an easy conversation to have. Yeah.
Because with the decision-making act does, if you have 5 kids, they all are equal. So if you don't have a healthcare proxy, there's nobody.
As long as they're older than 18.
As long as they're older than 18.
Right. So you have to make a decision. And guess what? We live in, okay, I'm an Eitz Chaim. I daven in Queens Valley. I'm sure there's people here that daven in other shuls. We live in a time where if you have a lot of children, they also follow different rabbis. Not all the kids follow the same rabbi, right or wrong?
Right.
Okay, so guess what? There's a lot of machloket that takes place because people go to different people. You have to make a decision about who you want. Who do you trust? Who is your